Welcome to RSCP. My name is Ben, and I'm going to discuss chest X-ray cardiac pathologies. The goal of this lecture is to be able to recognize and describe different pathologic findings of heart disease on chest X-ray. On the right, you can see a normal chest radiograph. Some of the things you want to evaluate on the chest radiograph is the cardiothoracic ratio, which you take the cardiac width and divide it by the thoracic width. And in patients with cardiomegaly, these patients' cardiac width is greater than 50% of their thoracic width. Also, you can look at the upper zone vessels, which are normal in this chest radiograph, meaning they are smaller than the lower zone vessels. The lungs are clear, no signs of pulmonary edema, and the costophrenic angles are well defined, meaning no signs of pleural effusion. When evaluating these chest radiographs, it's important to be cognizant of the pericardial fat pad you can see in some patients. This can commonly be mistaken as lower lobe pneumonia, or if it's included in the cardiac width, it can falsely make it look like a patient has cardiomegaly. When evaluating cardiomegaly, it's best done with a posterior anterior chest X-ray. However, sometimes an AP film is all you can get. You want to make sure the patient's not rotated on the table. One way to check this is by finding the spinous processes and making sure they're at the midpoint between the medial ends of the clavicles. And in this patient, you can see they have cardiomegaly. Their cardiothoracic ratio is approximately 60%. And anything over 50% is considered cardiomegaly. On this radiograph, you can see a patient who had a mitral valve replacement and has signs of enlargement of the specific heart chamber, specifically the left atrium in this patient. As the left atrium enlarges, it can push up against the carina, causing it to become more splayed, greater than 90 degrees. Also, you can see a double right heart border and also bulging of the left atrial appendage. You can also see calcification on these imagings. In this patient, you can see pericardial calcification. You can distinguish this from other calcification like aortic calcification because it follows the contours of the heart. It's an uncommon feature associated with constrictive pericarditis. Some other calcifications you can see are mitral valve calcifications. These are common in elderly patients, and they're often asymptomatic, however, may be associated with arrhythmias or valve incompetence. On the right is a rare left ventricular aneurysm, which is a common complication of a pretty large MI. And these can calcify and appear as a smooth eggshell line near the left heart border. Next, you can evaluate pulmonary edema. One of the earliest signs of increased pulmonary venous pressure is prominence of the upper zone vessels. Also, you can see septal lines, also known as curly V lines, due to interstitial edema, and airspace shadowing due to alveolar edema. You can also see pleural effusions on chest X-rays. On the right, you see a large right pleural effusion. In the middle, there's one that's more discrete, that's identified by blunting of the right costophrenic angle. And then here's a better look at curly B lines, which are the horizontal projections from the lateral aspect of the lungs due to interstitial edema. Another pathologic finding you can sometimes identify on chest X-ray is a pericardial effusion. This is classically described as a globular appearance of the heart on chest X-ray. It may be found in the presence of other signs of heart failure or may be found in the absence of those signs.